Hello, good evening and welcome to Face the Nation, coming to you live from Stein Studios in Ratnalan. Our topic of discussion today is one that I had hoped that we would not have to take up again. COVID-19, the coronavirus pandemic. Tonight on the show we're going to be talking about multiple angles through the COVID-19 pandemic. We're going to be looking at the efforts that are being taken by the health authorities, the steps that the public should be taking to minimize the effects of the pandemic and to minimize the spread of the coronavirus and COVID-19. We're also going to be looking at the plight of Sri Lankan workers who are overseas, and we're also going to be talking about the psychological aspect of the pandemic, the stigma around patients and those who test positive, and at times the stigma around entire communities as well. So let me quickly introduce our panelists to you, our guests this evening. Joining us today we have Mr. Mangala Randheniya. He is the Deputy General Manager and Media Spokesperson for the Foreign Employment Bureau. Thank you very much, Mr. Randheniya, for joining us this evening. We're also joined by Professor Atula Sumathipala, the Chairman of the National Institute of Fundamental Studies and Professor of Psychiatry at the University of Kiel in the United Kingdom. Thank you very much, Professor Sumathipala, for joining us. We're also joined by Dr. Deepa Gamage, Consultant Epidemiologist at the Epidemiology Unit, Ministry of Health. Thank you very much, Dr. Gamage. And Dr. Amanti Bandusena, Consultant Community Physician at the Health Promotion Bureau. Thank you very much, Dr. Bandusena. So I'd like to start this evening with Dr. Deepa Gamage as the representative of the Epidemiology Unit. Dr. Gamage, as at 7 o'clock for this evening, the total number of COVID-19 confirmed cases had increased to 4,842. Of course, this is from January to now. There are 1,512 patients who are under medical care and over 3,317 who have recovered from COVID-19. Dr. Gamage, what is the current status? What should we be worried? Should we be concerned about the spread? Is this a rapid spread? Has this been contained to a cluster, or is this the dreaded what people refer to as community spread, what we're seeing now?
Yes. Now, current situation, what we experience today is another cluster, and the cluster associated some other community cases. So actually the cases in our country, we are experiencing this COVID-19 pandemic situation from January, with the identification of this foreigner who was suffering from COVID-19. So then with that, our country started identifying cases, and the active case search started even from January. We have started active case search, and as a result we have identified that foreigner, those who has come from Wuhan city to Sri Lanka. And after that, until early March, we didn't have any cases in the country, but after that we were experiencing cases. So the most of the cases we have experienced were import related cases at the beginning, and then as clusters we have identified some religious, those who have gone to religious activities and came back. And then we have experienced some local transmission as clusters in different areas in Colombo and then some other areas. And then after that, gradually we have experiencing two big clusters in Navy cluster and in the Kandakadu cluster. So those two are also institutionalized. Those are not in the community but mostly institutionalized, but we have seen community cases because some of them have gone home and they have transmitted to some of their family members and also to their relatives, and some of the service providers associated with those Navy as well as this Kandakadu. So we have seen some kind of community cases, but somehow we could contain these two outbreaks without going into community transmission.
With the current, sorry to interrupt you, Dr. With the current cluster in Minuangoda, which originated, I believe, in Minuangoda, What is the status of that cluster? Has it been
Yes,
contained?
that is why I'm trying to tell the difference of these two institutionalized, and after that we have experienced only the COVID-19 cases only among foreign returnees, Sri Lankan foreign returnees mostly, and some foreigners also. And we were so happy because it is only, we have seen cases only in quarantine centers, and we ensured that those who are going out from quarantine centers are not transmitting COVID-19 to the community. With that, people have built up some confidence, thinking that we don't get any cases, but unexpectedly, I call that, rather than Minuwangoda, the Gampaha. So started in Minuwangoda, but now it's like a Gampaha cluster in Gampaha, and some cases associated to this Gampaha cluster. So this is not institutionalized. We have identified that in a factory first, but those people have not staying in that factory. They are staying outside. So they have had lot of community interactions, lot of travels, and country is open by this time, and people are involving in routine activities. So because of that, now we see a bigger community involvement and lot of cases among the community. So we see this as a cluster. We are trying to respond to this extensive cluster, and we see even beyond Gampaha, we are seeing some cases.
Dr. Kamake, do you see any possibility or any probability that we might have to enter into another lockdown in order to contain this, or are the authorities, the forces currently well equipped enough to contain this current outbreak?
Yes, at the very beginning we have had a discussion on that, but the strategy practicing at the country now is the new normalcy. So then that means if there are any outbreaks, while the country is functioning, we have to contain these outbreaks. So that is the practice at the moment, but localized lockdowns can happen. But at the moment, while we are trying to contain the outbreak, while the country functioning is happening at the normal way.
Without a countrywide lockdown?
Countrywide lockdown and this special district-wise lockdowns will not be happening at the moment. But if the situation is increasing, it is very difficult to predict at this moment.
Just one final question before I move on to Dr. Bambusena. When looking at the current status of our healthcare infrastructure, has it been strained in any way because of the COVID-19? Now, I understand that the epidemiology unit also has to deal with like COVID-19, although that's the main topic at the moment. That's not the only disease that the epidemiology unit deals with. Has the COVID-19 pandemic, in terms of your infrastructure, has it in any way strained your ability to respond to other situations like dengue, for example?
I think it is happening now because we are having in our country human resource and other you said that infrastructure, other resources for the infrastructure is very limited because we are giving the maximum care or the maximum output we are trying to get within this limited resources. So strain can happen, yes, but for the moment maximum effort is putting for COVID. It is true that we are not only, the COVID is not the only communicable disease we are handling. So we are responsible for outbreak control and the control and prevention of all the communicable diseases, including giving the vaccination to children for prevention of other communicable diseases. So all responsibilities are held by the epidemiology unit. It is true that because of this COVID-19 control activities, the strain is there for people because of the limited human resource and the limited other resources.
But are those programs functioning at present? Like, for example, immunization programs like for measles, mumps, rubella, etc. Those are all functioning as per normal or as best can we expect?
Surveillance, communicable disease surveillance and the immunization program in all other districts are happening at the normal way while we are putting our effort for COVID-19 control, but there is some deficiencies or the lack in the Gampaha district in some areas, most of the areas.
Thank you very much, Dr. Deepa Gamage, consultant epidemiologist at the Epidemiology Unit, Ministry of Health. Next, we turn our attention to Dr. Amanti Bandusena, consultant community physician at the Health Promotion Bureau. Dr. Bandusena, what is the role of the Health Promotion Bureau right now?
Good evening, and thank you very much for having this important discussion. So that is very important what the Health Promotion Bureau, what we are promoting and advocating is the proper behaviors, adherence to proper behaviors by us all, and the general public has a very great role to play here in controlling and preventing the transmission of COVID-19, because I think in general we have tended to get a bit complacent and kind of slip back on all those behaviors, the good behaviors that were safeguarding us that we were practicing. So the Health Promotion Bureau is always promoting these behaviors that we do need to practice. And in addition, we also have a large role with community empowerment and in producing the communication material, the communication messages that should go to the community, and in general playing a supportive role with regard to the communication needed to control and prevent the transmission of COVID-19.
Dr. Bandusena, when looking at the current situation with the public response, not on the part of the authorities, but in how the public are responding to this crisis situation, are you happy with the manner in which the public are currently responding to the COVID-19 pandemic?
Well, that's a bit difficult. Well, I mean, some of the public, yes, they certainly are strictly adhering to these practices and they are very vigilant. But at the same time, we do see lots of people who are not very vigilant and who are tending to slip. So I think in this context, it's very important that we practice. I think the people may have heard of the dream concept. So that is mainly focusing on the distancing or the physical distancing, then practicing the correct respiratory etiquette, then having the aseptic techniques of hand washing, and like avoiding unnecessarily touching your face with unclean hands, and of course wearing the mask and using it correctly. I think those are the key behaviors that the public really needs to be very much aware of and constantly practice, because with the earlier clusters getting under control, we have tended to get a bit complacent. So these practices do really need to be practiced to the full now.
Aside from public complacency, Dr. Bandusena, what are the biggest challenges that your bureau is facing in executing your duties?
Well, one is getting because knowledge is one thing, but practicing what we know is a challenge. So that is a challenge that we do face. Then also sometimes making sure that the messages do reach the targeted people, especially the most vulnerable people. It can be a bit of a challenge sometimes. And of course addressing stigma, because stigma has also come up as quite an issue in this situation. So I would think those are the key challenges that we are facing with regard to COVID.
Thank you very much, Dr. Bandusena. And on the topic of stigma, I'd next like to turn my attention to Professor Atula Sumatipala, Chairman of the National Institute of Fundamental Studies and also Professor of Psychiatry at University of Kiel, United Kingdom. Professor Sumatipala, we've seen the stigma associated with COVID-19 patients has evolved since from January to now. Initially, it was more of when the virus was overseas and not here. It was more of it has evolved from xenophobia to then now targeting individuals and individual communities sometimes. How do we tackle this problem of stigmatization?
Thanks for inviting me to participate in the discussion, which is very timely. So before I answer to your question, let me try and add to what Dr. Bandhusena said. So let's try and understand what's going on right now in the context of 1 year's experience of COVID. Let's understand what is going on in people's head, the way they think, the way they feel, and the way they behave, which has an impact on many different things. At the very beginning, when we first heard about COVID, there was a reaction. That's a normal human response to that. So rather than, I'm not going to talk about mental illness per se, but at the very beginning it was panic, people were buying things, people were worried about death. Then the second stage comes, that's where the complications come, resilience. I strongly believe we are a nation of resilience, having gone through many traumatic experiences, but at times that resilience can bounce back counterproductive as well. Then people start reopening, recovering, and as Dr. Lianage said, we came to a new normal growth phase. But going through this, I'm actually following up, I'm leading a study where we are following up all the COVID patients with the permission of Ministry of Health and Ministry of Defense to try and understand people's lived experience. So in that, what we have found, and also Ministry of Health has done some studies on stigma. What happened actually, there are three levels of stigma. Perceived stigma, which is common to any illness. Then social and public stigma. Perceived is what you think, how you are affected, and the second part is social stigma, where how the people and the society thinks, and the third is structured stigma. So right now what is happening, people in their mind, what we found, quarantine is a punishment for them. They are stigmatized. The Ministry of Health study shows that particularly the service people, and they have been sort of targeted through hints and things, avoiding. It has affected how they behave. And also the people, you saw recently, people escaping from the buses and all that. And in their mind, quarantine is a punishment for them. And with the impact of stigma, they try to avoid. On one hand, the experience is great majority is not dying. At the same time, great majority is recovering. So for them, they have come to this perception. I'm not necessarily saying this is right, and that's what is happening. So to me, the way I look at it from as a behavioral strategist, the political leadership has done the maximum. Our health forces, great, my hat off to their dedication, done their maximum. The forces have done. So their commitment is not matched, as Dr. Bandhusena said. The great majority of people are fine, but there is a percentage of people who have not understood the commitment by the forces. When I say forces, health forces, armed forces, political force, everybody, for us to have only 13 deaths and limited numbers. The way I look at this cluster coming up in Gampaha is partly because of people not taking responsibility for their behaviors. The perceived way of thinking about the illness. So I think that's very important to understand. So only if we understand how people think, behave, then only we can have our strategies to try and prevent. The Family Health Education Bureau is doing great work, but as Dr. Bandhusena said, knowledge is one thing, attitudes and behavior are a different thing. So,
Professor Sumantipala, we've seen, I mean, this is not a widespread report, but there have been individual cases of people trying to avoid quarantine. As you mentioned, maybe there's a perception that quarantine is almost like a punishment. What leads to that kind of, what causes that kind of perception to arise, and how can we deal with it?
Yeah, one thing is actually any human being, when you are diagnosed not only with COVID or threat of COVID, even if diabetes or cancer, some people cope by denying, what we call in psychological terms, it's denial. In their mind they believe, no, it's not going to affect me, I'm not going to be ill. So that leads to avoidance on one hand. Second thing, the perceived stigma leads to avoidance on the other hand. So what we really need to do is to educate the people, and the media has a big role to play in targeted risk communication, because the message to upper middle class educated people is very different from how we should communicate it to the lower classes, and particularly like places like slums and all that. So this has to be targeted and very clearly strategized by understanding how people think and behave. So it has to happen, and the media has that role. Compared to I coordinated Sri Lankan tsunami, the media behavior has improved a million times, I would say, but there's still a lot of things the media can do to help what the Health Promotion Bureau and the Ministry of Health and Epidemiology Unit as well as the forces do by doing it. Particularly the coverage of COVID, sensationalization is counterproductive, and I think we shouldn't, I mean now you actually black out the faces, but still even identifying places, houses, it can have a counterproductive impact on the people, and particularly getting into stigma and avoiding help.
Professor Smithipala, a key difference between the time when you were coordinating the tsunami back in 2004 and now is the emergence and widespread proliferation of social media and the way that social media operates right now. We see how even through messaging services like WhatsApp, even on Facebook, on Twitter, even on YouTube, there is a lot of disinformation and misinformation that is spread with very sensationalized sort of topics. For example, even these lists of names of patients and their addresses, their personal information that has somehow leaked, and it comes through, it spreads like wildfire. I mean, the mainstream media, the official media, let's call it, like TV stations like ours, registered news providers with the Government Information Department, the quality of the information that's coming out from there, or the veracity of the information can be not controlled, but can be, you can do the kind of targeted risk communication that you're talking about. But how does one even begin to go about controlling the fake news sort of mill that is the social media landscape?
Yeah, you brought up a very important thing. To me, social media has become counterproductive. As you correctly said, it's disinformation, sometimes deliberated, targeted misinformation by, I would call them, it's again a behavior of part of a group of people who have a different psychological frame trying to capitalize on a situation like this. So it has to be controlled. I'm sorry to say this, I'm a strong believer. If people cannot be educated on social media behavior, it has to be controlled, because what I look at it, particularly from a public health ethics perspective, the greater public good is what we really want. That's the principle even in public health preventive medicine. It's same in social media. The printed media and also electronic media, people like you all, are more responsible, are accountable, but these individuals sometimes just behave in a very counterproductive way, which we need to handle. Sometimes, most of the times, ignorance can be defeated through awareness raising, but arrogance cannot be defeated through awareness raising. Arrogance has to be dealt with by other means. So I think the authorities have to take it seriously. If people deliberately violate things, that has to be contained. On the other hand, responsible social media users have a responsibility to try and communicate as much as possible, taking from the authoritative sources and punching on the same point to disseminate, because social media has a place. I do accept that, but currently I think it's going in the wrong direction. So
Professor Sumitipala, before I move on to Mr. Randenia, very quick question to you. We've seen some anecdotes that have been shared on social media, people sharing their own experiences or their neighbors' experiences. I'd like to share one with you that I saw today. It was posted where it was alleged that to the residents of a person who had tested positive for COVID-19, authorities had turned up with sirens blaring, almost as if they were there to make an arrest. In that kind of climate, isn't it difficult to get people to change their perception of, being COVID-19 positive is not a bad, it's not a negative thing, it's not something that you should hide away, when the response on the part of the authorities is sometimes perceived as being heavy-handed? What would your advice be to the COVID-19 Operations Center, to the authorities in charge of this thing? For example, when it comes to doctors, we see that doctors are trained in bedside manner. How do we sensitize our police force, for example, our tri-forces? How do we sensitize them to have that kind of almost like a bedside manner?
Yeah, you brought up another very, very important thing. This awareness raising has to happen laterally. I personally believe, I'm not saying this because I'm a doctor, the doctors are better trained in dealing with this type of situation, because we know, one of the things people don't know much, we have excellent public health system in this country. I work in UK, but I had 3 trainees from Sri Lankan public health system there. When they came to my university, my colleagues said, why are you here? You all have better health system than us. And they actually got involved in teaching. So with that background, we have very great force. We have got consultant public health physicians like both of them. Then we have PHI, massive army of people. They are very well trained to handle that. Unfortunately, the forces, with great respect to them, they are dedicated, they are not actually tuned to that level. So this awareness raising has to happen laterally, and each and every person involved. So my advice would be, if a team goes to take people on quarantine, I think the health people should lead that. That's my personal belief. I'm not blaming, because it's a very delicate, difficult situation when you have to contain. But again, that shouldn't be portrayed by the media or perceived by people as a punishment. The message should be, even if the media highlight that, it has to be positively framed, saying this is for your benefit, this is for greater public good. We are temporarily removing you to a place of safety to try and prevent, because as Dr. Lianage said, if the health services are stretched, we may not necessarily have deaths from COVID, but we may have deaths from other illnesses. And we have to be very mindful. Doctors are human beings as well, nurses are human beings as well, the other staff are human beings. There can be a burnout. The forces are better trained to prevent burnout because they have gone through 30 years of war. But health professionals are different. So I think my message to everybody, every strata, this is a great team game.
Professor Sumitipala, in a team game, there has to be leadership from the very top as well. When talking about perception, isn't it also important that the political authorities lead by example? We've seen instances where top politicos, from the head of state to top ministers to even opposition MPs and opposition politicians, not adhering to the rules that they're asking the public to adhere to. So doesn't this also contribute to the cynicism on the part of the public?
Absolutely. There are plenty of opportunities for improvement. I totally agree with you. And the politicians has to be educated, on this, because they are from diverse groups. But I am happy with the top political leadership, particularly His Excellency the President, who is giving a great leadership to this. We would have been a different nation if not for that. Our COVID center started on 27th of January, even before the first patient was diagnosed. The political leadership and commitment is definitely there. And in terms of leadership, I also admire, I mean, one of our strengths, as I told you, the public health, but if we didn't have the forces involved in it, it would have been, I'm sure you will agree, if it was a calmer, different environment with communicable diseases, the public health system would have coped. But this was something we were running against the time. So I think the leadership is there. They have done their utmost. And however, it can be strengthened in every sector. There's more provision for strengthening, minimizing our weaknesses. We need to learn from the mistakes, thinking back, where have things gone wrong. And it's not for a blame game. My message to all the politicians, forget your party politics. This is a nation's threat. Get united. Don't look for political mileage. Look for nation's benefit. That's my plea to all the politicians.
Thank you, Professor Sumati Pala. Next to move my attention to Ms. Mangala Randheniya, Deputy General Manager and Media Spokesperson for the Foreign Employment Bureau. Ms. Randheniya, another aspect of this pandemic that is often forgotten or is overlooked by many stakeholders is the plight of Sri Lankan citizens who are working overseas, predominantly in the Middle East, in countries like Korea. At present, how many Sri Lankan expatriates are still waiting to return home? Does the Foreign Employment Bureau have an idea of how many people still need to be repatriated?
Yes, thank you again for inviting us also to take part in this important discussion. So when we look at the registration numbers, the missions maintaining, we have still very much close to 48,000 waiting to come to Sri Lanka. So that is the figure that presently we can observe. Gradually we could repatriate the most wanted the Sri Lankan expatriate workers. So it is calculated up to almost 30,000 by now. We know this foreign employment sector is the major contributor to the national economy, and although we provide annually 200,000 employment in overseas, in this year we could provide only by now 45,000 people the employment in overseas. So we experience still the most of the labor destination countries are in lockdown situations. There are airports working only for the most wanted things, not for welcoming migrant workers. So there is a limit by now. But we tried to open this foreign employment sector by discussing with some of the agreement signed countries, government to government agreement signed countries, the destination like Korea and Japan and Israel. So we are still in a certain level of negotiation. The Korea, of course, they slightly open their market for our Sri Lankan qualified workers to come, and at the same time we have almost 1,800 agreement finished or agreement over completed workers to come back to our country. So in order to even send workers, we need to repatriate the contract completed workers back to our country. So otherwise those we will not be able to get those opportunities. So now the present status in the foreign employment sector is at that level, and we are somehow some countries like in Middle East, UAE is to a certain extent open for Sri Lankan workers. some flights movements are there, and they take those opportunities and go for overseas employment. So by now it is almost 50,000 workers got the SLBFE registration for overseas employment.
Mr. Andini, we've seen numerous Facebook groups that arose during the lockdown periods overseas with people, with migrant workers stranded overseas. There was groups like Sri Lankan migrant workers stranded in Dubai, Sri Lankan migrant workers stranded in Jordan, and there were very tragic stories that these people were saying. What kind of, regarding their inability to even feed themselves, what kind of steps has the Foreign Employment Bureau taken together with, for example, the missions overseas with the Foreign Ministry? What kind of steps have been taken to ensure the welfare of these people, to ensure that they are, while they're waiting to be repatriated, that they are being taken care of?
Yeah, until we get the fully crowd repatriated, we are maintaining a welfare, the package or the initiatives for these the waiting people. Now we are maintaining labor sections in 16 areas, like 14 countries and 16 the foreign missions. So the labor section carried out several works to support for migrant workers. They were provided dry rations and then for some people shelters, and with the negotiation with the government organizations, they were provided the required quarantine, and at the moment it is 2,600 Sri Lankans infected in the Middle Eastern countries and some of the East Asian countries like Korea, Singapore and Malaysia. So they continuously we are looking after their requirements, but providing shelters for the people who lost jobs and their accommodations is a kind of a difficult task, and at the same time there was another important issue came out, like now we know almost 900,000 Sri Lankans are working in these destinations, like this the 14 countries. Out of these 900,000 the Sri Lankans, there are Sri Lankans who do not have the legal documents to stay the country legally, but they work and stay. So when they work and stay, when this type of situation comes, they are being challenged. Their movement is drastically challenged since they do not have the valid the work permit. Then they don't have this insurance with them. Without having the work permit and the insurance, they are not permitted for hospitals. And the employers who have provided temporary jobs and informal jobs, they also started not giving. They stopped giving such odd jobs for those workers who were performing. So then they faced this situation. That's why they had to come to the road and come to the missions in front, and they requested some supports from the mission. So once we listed the registered people according to their wants, like prioritize the expected population, come back to Sri Lanka. Some of the people were given this opportunity, but due to this the limitations available domestically, like quarantine places and the number of PCRs that can be conducted and the number of beds available in designated hospital for the COVID-19 patients. So those limitations came in front, and due to that situation, the repatriation cannot be expedited as expected. So by now the repatriation is temporary of course the whole, but we are expecting to get some more workers.
Mr. Randhania, what steps have been taken to address these limitations? I mean, with quarantine centers and things like that, you can add more resources so that you have a greater number of beds or rooms, a greater number of quarantine centers. So what steps have been taken to address the limitations?
Yeah, I take part in the subcommittee of this COVID-19 repatriation. So there still we are not in a position to expand the numbers, because during the lockdown period, the COVID-19 National Center had a lot of accommodation, a lot of places. But once the country was open for normal economic and social activities, so then we had to hand over those places which were used for quarantine. Now the sites and the places are certain limitations are there. Only thing is, according to this the technical the guidelines, we cannot even fully occupy. We have to have always the reservation for unexpected situation to be catered. So though we do have places for 30,000, we can't fully occupy the total number of beds and places, because we don't know the situation how that is been happening in our country domestically. So that what we expected or we requested from the employers through our foreign employment agencies and through the missions staff, we requested employers to extend the workers the period of the legal workers agreement or the duration, the contract period. So the majority of our workers got contract extended. That's why the 90,000, almost by now it is 150,000 people should have come back, but still the waiting list is around 50,000. It is why that number is there, because of the
Contract extension.
So we appreciate the host countries' employers and the receiving organization in those countries. So they accepted, and even re-employment and alternative employment opportunities were also offered for Sri Lankans who are in that situation. So somehow still we are expecting the same thing, and we execute that activity still in the destination countries, since having understood the limitation here in Sri Lanka.
Thank you very much, Mr. Randhania. Let's open the floor for questions from our three journalists this evening. On my immediate left is Jayamal Ratnayaka, on my far left John Fernando, and on my immediate right Deshan Gonawala. Let's start this evening with Jayamal.
Thank you, Nadeem. I'd like to direct my first question to Dr. Deepa Gamage. Doctor, we heard earlier today that officials claiming that the virulence of the virus that is affecting the country in the third wave of COVID-19 infections has increased, or the viral load has increased this time around. Is there any truth to this? And if so, how has the epidemiology unit how is it trying to counter this situation? How are you geared up to counter this situation?
Yes, I think some kind of explanation has given the question for you to ask that. So it is not that the virulence has increased or the viral load has increased. So when one person get infected, so then the viral load, if that person's immunity, as the immunity develops, the virus is multiplying within the body. The virus enters, virus is multiplying. So when the virus is multiplying, viral load is going up, and its virus excretion also increasing. Then the immunity is developing. When the immunity is developing, the viral load, the excreting virus load is going down. So this time what we have seen, it is not that the viral load has gone up in one individuals, but what we have seen is lot of people in that initial identified company, there are lot of employees we have identified infected at the earlier stage. So they very recently they have got infected, lot of people have infected at one time. So usually what we have seen in most of the countries, when get infected, these people will transmit to other people. So it gradually going on. Even in other clusters what we have seen, this is the picture we have seen in Sri Lanka. So it gradually transmitting to others. So when we see the cluster, when we get one cluster, different people are at different stages. Some people are at the recovery, some are at the initial, so some are at the middle. So but here what we see is lot of people are at a very high, the initial stage. So lot of viral excretion is there, because that means initial 3-4 cases have not detected within that company. Because of that, those people have transmitted that quickly to lot of other people, other employees. Because of that, lot of people, when we detect the cluster, lot of people are excreting high load of virus because they are at the initial stage of viral excretion.
So Dr. Gamage, we saw certain cases where the patient contracted the virus, the patient was taken in for medication and then was released back into his or her household, and then a few days after contracted it yet again. How can you counter such a situation when that occurs?
You mean the same person have
Yes,
contracted the disease? No, it is not.
There have been certain reports
in our
where
countries. No, it is like this. Maybe the 1 or 2 instances you are referring because of the lab reports. Because of lab reports, some confusion for 1 or 2 people. But it is not that people are getting infected repeatedly. It
because
has not
there was a scare that people who recovered from the virus have contracted it yet again, and there was quite a lot of discourse regarding it. That is why I am directing the question to you.
This is a new infection. So new infections, the epidemiology of the viral diseases are gradually identifying. So in other countries also we have to get the evidence from the other countries. So in other countries also this kind of instances have not seen that people get infected, develop the immunity, then after that getting infected again. So this kind of instances have not seen. So when we develop the immunity, once infected and develop the immunity, so then immunity will not go down quickly. So that will give some protection for some time. So in world evidence it's also not there how long this protective immunity will last. But viral detection, as you said, it can happen in this way. Sometimes the intermittent viral excretion. So this test may be positive, the next test may be negative, and then another one may be positive. That doesn't mean that people have got infected again. The same virus, the intermittent viral shedding has been seen. So that has been explained for this viral disease. So at the time, that also depends like this, intermittent viral shedding as well as the quality of the swab collection, the expertise of the way of collection and the time of collection. Sometimes if the viral transmission is, the viral shedding is not there, when you collect you will not catch the virus. So that is why the consecutive tests are vary.
Right.
So it doesn't mean that, people are getting infected again and again. You will detect the virus at several occasions.
Dr. Gamage, very quickly, we've seen on the question of testing, we've seen a lot of private sector operations that are advertising testing for COVID-19. Who should be getting tested at this point?
Yes, the thing is, it has to be for the, even for the private sector, it has been given the advices from the health ministry. It should not be on advertising, but it has to be identified by a medical doctor for the requirement of testing. Because of this available resources, we have to use for the most important and the relevant people. So these doctors know on identifying the relevant people. Relevant means those who are having signs and symptoms, those who have contact with an infected person, and if they are coming from possible risk areas, like a lot of people are coming from those areas, so identifying risk areas. So based on such identifying categories need to be subjected to test. Otherwise, the widespread advertising and doing the testing, we have not gone up to that level.
So we've seen, so basically if you have the symptoms, go see a doctor, and the doctor should be the one to recommend testing.
Yes, it is called, even our country, we have had that testing strategy in the country. We called influenza-like illness. This COVID signs and symptoms are somewhat similar to influenza. It's a respiratory tract infection. Fever, respiratory tract infection, sore throat and difficulty in breathing, runny nose, so and cough. If person is having that kind of some signs and symptoms similar to influenza-like illness, we subject them to COVID testing. So this has been happening throughout the country in different hospitals, identified hospitals throughout the country. So in addition to the community normal high-risk testing, that is one strategy, and influenza-like illness patient testing was another strategy we have been practicing throughout.
Dr. Bandusena, I want to ask you something along the lines of what she was saying with regard to who needs to raise alarms for themselves and how that needs to be done. Particularly what you've seen is, especially if you look at the last cluster that has come about, there were a few complaints from a few parties saying potentially that these infected individuals were not necessarily directed where to go and how to seek treatment, and at the very end they had to decide to go to a hospital. Do you think that the Health Promotion Bureau is doing enough, firstly in terms of informing the general public about the steps that need to be taken if you suspect that you have an infection, number one, and number two, also with regard to how one should act, especially when they do go to a public place like a hospital? Is there enough being done in your opinion?
Well, yes, I think the Health Promotion Bureau has been telling the public what they do need to do, and if they do have symptoms and signs, how they should proceed. And not only the Health Promotion Bureau, the local health authorities have also been directing the public as to where they should get help. And of course, the Health Promotion Bureau has a 24-hour hotline service called Suvasariya, where the public can call at any time and raise any queries if they have signs and symptoms which are suggestive.
Can you share that hotline number with us maybe?
Yes, it's 1999.
Okay.
So that is open 24 hours, and we do get many calls on that hotline. So that service also helps to direct the people who call to the appropriate services. So Health Promotion Bureau is doing the utmost to direct the people and to educate regarding the symptoms and signs. But of course, as I would really like to repeat that it is the duty of all people really to take precautions. Because what we see as earlier, these behaviors need to be practiced. And you are asking whether there are any kind of people who may be a bit more at risk. So there, when we consider the elderly, especially those who are over 65 years of age, then those who are having non-communicable diseases or chronic diseases like diabetes, heart disease, cancer, etc., these people do need to take extra special care because their immunity is anyway a bit less than that of the average person. So messaging, relevant messaging is going with regard to that, and of course through public address systems in the medical officer of health divisions also, the Health Promotion Bureau has been coordinating with them, and we have our field officers, the health education officers. So they are in communication with the Health Promotion Bureau and at district level with the medical people there, the regional district, the director of health services at district level, and with the MOHs. So there is always a network and coordination. It is a team effort which is happening all around.
Professor Atula, staying on the same note now, lack of responsibility like you mentioned before. If we draw attention once again to the specific case in the factory in Minuwangoda, over 1,300 workers were infected by the COVID-19 virus. Now, we should not forget that this infection or this incident did happen against a backdrop where stern medical or health procedures were followed by the whole country in a whole. Yes, it's justifiable if this incident happened when this pandemic emerged, but we should not forget that this incident happened when the whole country was practicing health guidelines. So how can we make sure, other than these health guidelines that we already practice at the moment, definitely like you mentioned before, there is a psychological or responsible aspect that will play a key role into this whole operation. What are the steps that we should take in order to make sure that this such an incident will not be repeated? Maybe implementing rules and regulations with a strong legal framework, or any other sort of action like that to make sure that this will not happen again, because as always, prevention is better than cure.
Yeah, vigilance is the most important thing. Every citizen has a responsibility for that. Every factory owner, every manager. It's like, can you remember when we had the 30 years of war? People were talking about winning the war by sending the next door neighbor's son to the war, not their own son. But it came a time where everybody was committed. People didn't desert from the army, but instead people went and joined, because that became the nation's responsibility. That went into everybody's heart and mind. People played their role in many different ways. People were donating things. So that level of motivation has to be imposed in the country. That's why exactly what Dr. Bandusena said. Engaging people is very different from involving people. You can send circulars, the factory managers may be involved, but it's not that. They have a responsibility to engage, because the Health Promotion Bureau or the Epidemiology Unit or the COVID Center can't be behind everybody checking, or the President or the politicians or the Prime Minister. So to me, as a behavioral scientist, psychiatrist, it's the most important thing, everybody to retune. This is a nation's challenge. So taking the responsibility into your hand, not waiting till somebody else tell you. It's like the helmet thing, you know. I mean, there was a time where people were not wearing helmets, they were carrying it. They were wearing the helmet only if they see a policeman. So we should be wearing helmets not because we are worried about the policeman, because we are worried about protecting our own heads. So every citizen should be, you know, made to think so. So the media, everybody's responsibility is we have to start sending all these text messages, or all the media, you know, the taglines and everything, to try and get back to that vigilance and work together as a nation, realizing what's your responsibility. And that's what the health promotion people call public engagement.
Professor, if I'm to expand on that question now, I feel personally this boils down to self-discipline of an individual. And we've only seen a handful of countries, if I may, New Zealand, that have completely controlled the spread of COVID-19 purely because of the self-discipline of its citizens. Is it too little too late for Sri Lanka to teach self-discipline to our citizenry, or what can we do to promote it?
I don't think it's too late. You would remember when tsunami came, before even the health services moved in, the people in the vicinity moved in. Before the water bottles were airlifted from states, people took water to our own people. So our nation is a very helpful nation. They can be motivated. I'm a great believer of it. The great majority can be mobilized. But there would be a relatively lower percentage who may have to be dealt with other means. So it's a combined effort. But I think it's not late at all, but it's a matter of everybody preaching. The Buddhist priest in the temple, the the clergy in the church. This should be our main thing every day, every practice, every time people get together, talk about it and advise how to do. Every teacher's responsibility, every principal's responsibility, every lecturer's responsibility. Before you start a lecture, my advice would be mention about this, so it becomes a sutra, mantra. Like people, once you repeat the same message, even the wrong message, remember that's where the Goebbels came in the Second World War. When you repeat the message, it gets registered. So it's a matter of repeating at every level, every possible way. That's our nation's target right now, in my opinion. And if you do that, we can help all the other forces to win this war.
Dr. Bandusena, one of the with the rise of this new cluster, one of the questions that a lot of people have been asking is around, because after the easing of lockdown, people were able to go back to work. During the lockdown period, many people, not all, but many people adopted a work from home policy. Many companies adopted a work from home policy. Given the current situation, should the private sector and public sector, where possible, should people be looking at, should businesses be looking at, or should companies be looking at moving back to a work from home policy?
Well, I think that can't be a blanket decision. It would depend on the individual companies and the individual factors in operation. But if people do take the relevant precautions to safeguard themselves if they do not come to work when they are ill, when they are having respiratory symptoms, etc., and if they do take personal responsibility, and if the workplace and the management also has a conducive environment for people to responsibly, practice, then I don't think it is a problem to have people coming and working on site, because there are certain companies and businesses which would definitely need people to come and work on site if they are to continue without losing on their business. But then, of course, where there is an option of having staff working from home, because there may be people who can very well do their work online, well, then it is up to the management to do that, because then there is no reduction in the work output, and they are safeguarding both their employees and the company. So I think that would have to be taken individually.
Dr. Gamage, on similar lines, do health authorities recommend that where possible, or where it is convenient, that people should be working where, if, for example, people who can be doing their work online remotely, do the health authorities recommend that that step should be taken?
I think in the guidelines it is already given for, it is not as she said, it is not as a blanket cover for everybody, but for some categories. So the advice or the recommendation from the health ministry which has been given for the workplaces is to minimize the number of people, those who are having interactions. So I think that is the message. So if the interactions, to minimize the interactions, if some categories are there to those who can provide their services online, yes, for those categories, yes. For some categories it cannot happen. So they have to work on site. So for them there should be another strategy to make sure that less interactions are happening. For when we are taking for all these, each and every patient we are approaching through approaching to get the history. So how we are trying to identify from the epidemiology unit, we are trying to identify who are the contacts and how these people have got the infection. So during that taking histories, we have identified that in some workplaces, most of these affected people within those workplaces, they have not adhered to minimize the interactions. So all the messages are displayed. So they have adhered to, one example is checking temperature, but when the fever is there or the temperature is high, they have not taken actions. But as Professor Sumiti Palace said, how to engage people, they know this has to be done. So minimum meter distance has to be maintained. But how how to engage into this. I think that has not been practiced already. Even though the health ministry recommendations are there, people have not practiced that within these workplaces.
Dr. Gamage, when you look at some, like for example, when you talk about maintaining the meter distance and wearing the masks and all that, when you take environments like restaurants, for example, where people started going to restaurants, and the meter distance and the mask only applies until you're seated at like the table, for example, or let's say in a workplace, sometimes you'd have people working next to each other, or in cubicles adjoining each other, they're not separated maybe by a wall or something. So is that also wrong? Should that also be stopped? For example, at workplaces, should there, whilst people are working at their desks, should the desks also be a meter apart?
Yes, I think that kind of advices have been given. If they can keep them apart, yes. If they can put a barrier, for the barrier of disseminating the droplets, barrier for droplet dissemination. So that kind of advice is given, and people have started when the country was at lockdown stage or the curfew was there. Then we coming out of that, people were started practicing that, and after some time they have come out of that, thinking that it is not necessary now. So this is what we have seen by talking to people. We have identified. So even within the workplace, they were thinking that no, it is not necessary now. No need to adhere to that. Now we don't have COVID in the country. So, but COVID was there in the country. Ports of entries continuously, people are coming from other countries, and the imported cases were there in the country. So I think people have forgotten that, thinking that because we don't have community transmission, everybody thought that we are safe. But what the practices they have started when they restart their companies, they have come out of that.
Yes, Professor.
Yeah, can I add to that? I mean, the classic example is the health staff is at the greatest risk, but because of the practice, it's minimum among health staff because they're practicing. So my suggestion would be like drills, army do drills. Every factory, every office, as Dr. Bandhusena said, can't be prescriptive. Guidelines is a general thing. Every whether it's a small shop or office, they should have drills, practice it.
Yeah.
And you need to propagate the idea that IDH hospital, the staff would have been the greatest risk, but they didn't get affected. Why? They were trained, they acted with responsibility, and they cared for the people. So this is the psychology and the mentality we should inculcate, and people should start making drills, checking in the morning, like the fire alarms. Our university in Kiel, whether there is a fire or not, the fire alarm rings every morning. So we are tuned to it. My suggestion would be that's the best strategy we can do right now in this country. If we do that, I'm pretty sure we'll be doing a great service to all these, I call heroes, who are in the front line.
So Professor Sumitipala, do you think that we should set the example at the top and maybe start with drills at Parliament?
That's fine. That's absolutely wherever it starts. But again, if they don't do, that shouldn't be an excuse for another person to do. We can learn from the right thing by observing it. We can also learn not to do the wrong thing by observing what people. So that's again how the behavioral strategies can be adapted for people to learn from good things from other people and not doing the bad things. So it doesn't matter which level. My advice, start the drill tomorrow.
Mr. Ramdhaniya, just a quick question for you. With the workers that are waiting to be repatriated, or the ones that are on the waiting list that have sort of then managed to get onto the flight, what is the procedure that is followed by the Foreign Employment Bureau, not the health authorities, but does the Foreign Employment Bureau have any sort of follow-up action that needs to be taken once someone is sort of shortlisted for a flight?
Well, the the people who are in the list. So only advice is they are continuously being advised through our systems, and we have organized communities in the destination countries, Sri Lankan communities, associations. They are well connected. Even we facilitate, we provide services through our communities. So what was the advice for them to be quarantined, live like the places where presently they are living, and very much related to the personal self quarantine until they get the chance to get into the flight. So that is the advice. And one thing I want to emphasize or explain, now almost 1,000 Sri Lankans got the repatriation from Korea. No one identified as the infected one from Korea, but not like other destinations. Other destinations, of course, we know during quarantine and during the second PCR, we come across positive people, but not like Korea, because even Korea, before repatriation, they have a PCR, and then they are coming here, waiting, and so they are fully safe. Like the advices being followed in those countries. Korea also, they are the country which has controlled to a great extent.
So in the Middle East, let's say, I mean, the other major sort of hub, being the Middle East, being the major hub for Sri Lankan migrant workers, when they're returning from flights there, don't they get a test before they board the flight? Or is the testing done only after they arrive?
There are countries where this mandatory test is being conducted, but the health checkup is usually what is being done is the general health checkup. But once they come here, of course, is a mandatory PCR is done. So that is the country's offer for everyone coming. Who are going for government quarantine, their PCR is done by the government. Who are going for private quarantine, like paid quarantine, the package includes the paid quarantine, package includes the PCR test also. So that is how presently we are moving with COVID-19, and those who came back, and we administer questionnaire with the returning workers to give them a proper reintegration program, the socio-economic reintegration program for the return workers. So most of them have informed that they would like to stay in the country here. Few like 25% of these people, they again want to go back to the original workplace at the destination country. So the Bureau of Foreign Employment is now in the process of facilitating the returnee workers' expectations. So we have to do it. So that is the present workload that we are doing for the migration industry.
Dr. Bandusena, what is your advice for, we see now a lot of young people have returned to work. So for people who are living with elderly relatives, with their parents, etc., who are in, let's say, the same residence, what is your advice to them to ensure that they do not unwittingly spread COVID-19 to their parents or grandparents or even other vulnerable people?
Well, yes, that is very relevant, because in our culture we do live with our parents and grandparents. So there is always the risk of inadvertently infecting somebody else. So this is where it is extremely important that we do shift to this new normal living style, because COVID is actually here to stay for some time. It's not going to go next week or next month. So everybody does need to adapt to that. So taking those precautions, like the hand washing, is extremely important. So if all the family members, especially the younger members who are mobile and who do go out, stringently practice hand washing with soap and water. Then the respiratory etiquette, where people don't just sneeze and cough, but they do sneeze or cough into a tissue and dispose of that tissue correctly. Or if they do not have a tissue with them at the moment, they sneeze into their elbow. So practices like that. Then of course, keeping, well, when you are interacting with your family, of course it's a bit difficult to keep, but we do recommend that the 1 meter distance is kept at all time. That is a
Even
physical
at home?
distance. Even at home, especially if somebody is having a cold or cough and you have your elderly parents or grandparents there, yes, definitely, because it is physical distancing, not social distancing. We can interact socially, but we have to safeguard each
physical.
other, yes. So wherever possible, the physical distancing. And of course, sorry.
Sorry,
And
go ahead, Dr. Lanka.
and of course, if somebody is having a cold or cough, it is best if they could wear a mask even within that, especially when they are interacting with a elderly member of the household. So these things would really greatly reduce the transmission. And of course, when it comes to going out of the house to buy provisions or something, it should not be the elderly who goes, but the more young and the more fit who should go and do that kind of thing.
Dr. Bandasena, the reason that I asked this question is because there is a sort of a perception, or at least there's a perception in our minds as well, that the physical distancing and all of those practices, the mask wearing, etc., only happens while one is in transit from work to home or work to wherever. So while you're in transit, while you're commuting from one place to the next, the physical distancing is there, but the moment you get to your destination, be it home or the workplace, the distancing kind of collapses. Could this be a contributing factor to the spread of COVID-19 that we're seeing now?
Yes, certainly that could be a factor if it is only in transit, because even at our workplaces, if we cannot, wherever we cannot maintain the 1 meter distance, we should definitely be wearing our mask, because if we each have our own cubicles, it's well and good. We can remove our mask and do our work, but where people are in a closed kind of space, and especially where there is air conditioning, no natural ventilation, then taking these measures is very important, and it should definitely not be only in transit, but at all times, because the mask is recommended, especially where the 1 meter distance cannot be maintained.
Dr. Kamake, we know we report patients as COVID-19 positive on the epidemiology website. It says that currently there are 1,514 patients who are under medical care. What percentage of these people who test positive, what percentage of them are actually asymptomatic, that don't show any symptoms? Is that the bulk of people who are being tested, or is that a smaller percentage?
Once we detect this Gampa outbreak, we have analyzed all the cases, and 70% what we have seen as asymptomatic. But here in this outbreak, I think we have not totally analyzed the cases, but based on the currently existing, the way we are getting the information, it may be little more than that. The symptomatic cases may be little more than that. It's like earlier 30% symptomatic, now maybe 40 to 45% symptomatic. So we don't know what would be the asymptomatic percentage at the exit, because most of the patients are still in the hospital. So this is the asymptomatic cases at the time of detection, the number has gone up. So others might develop symptoms little later while in the hospital. And the one thing I would like to add, what she was explaining, so to prevent the transmission within the house as well as at workplaces, I think they should not use the same utensils. We should not share the utensils. The plates, the cups, glasses, the person has to use their own ones. So it should not share within different people. And in the canteens also, the same glasses, same plates should not share. We have seen this kind of transmission among each other when they are sharing their utensils in common places.
Thank you very much, Dr. Gamage. Any final questions before we
Yes,
go in?
Mr. Randhaniya, if I may ask you this question. We heard a few days back that certain welfare officers attached to several countries have been called back to the island. Now we know that welfare officers are an integral part in protecting or safeguarding migrant workers in those nations. Is there a new mechanism in place for the safety of those migrant workers, or what is the reason behind this?
Yeah, that was a bit critical factor because that's an internal measurement we had to take that the cabinet of ministers the permitted to reduce the number of employees, number of staff in the labor section without disturbing to the normal routine works for the migrant workers. Now, due to this, the financial situations by the Bureau of Foreign Employment, we had to reduce to a certain extent. But with the staff of the missions, the mission is having we call it consular section staff, normally carrying out civil works for the Sri Lankan community. So we are joining with the consular section and carrying out the workload. Since we don't at the moment entertain new job orders and new workers leaving like the previous situations, we can work with the limited number of staff in labor section. So we will have, once we come to the normal situation, back to normal, so we will have the same staff deployed in labor section.
Thank you very much. Let's go in for the final round of comments from our panelists. So I'd like to start with Mr. Bangla Randenia, Deputy General Manager and Media Spokesperson for the Foreign Employment Bureau. Mr. Randenia, moving forward from this point now, you said that we have about 30,000 that are on the wait list to come back to Sri Lanka, migrant workers. There are others who've had their contracts extended, and legal workers who have had their contracts extended and who are not necessarily waiting to be repatriated immediately but may need to come back in the future. Then you have, you said, the workers who have either overstayed or who do not have the right work permits, etc. What is the plan to ensure the safety of these Sri Lankan citizens and to bring them back home whilst also ensuring the safety of Sri Lankan citizens here at home?
Yeah, now this situation provided the management of the foreign employment sector to rethink about the re-ensuring of the protection measurements that we have introduced for the migrant population. So we developed the 5-year plan, and at the same time COVID-19 responsive plan with the stakeholders of this industry like foreign employment license agencies, international organization, related ministries, together develop this COVID-19 the responsive action plan. So under which we have proposed different insurance schemes giving more protection and addressing their issues more than what we addressed earlier, and also more the bindings like new MOUs and new agreements with the receiving organization, receiving countries, and more about secured employment from most accredited and credible workplaces. So that is the new start for the foreign employment sector at post the COVID situation. So we are waiting and trying our level best to contribute to reduce this spread among the labor migrant population and who are leaving the country. Even we provide them a lot of guidance and advices on the behavior changes. So we are advising them to limit their movements, workplace to living place to workplace, no other the movement. So likewise they themselves being empowered and educated more on the aspect of prevention. And
Mr. Randani, just very quickly, is the Bureau of Foreign Employment the primary point of contact in terms of government departments? Is the Bureau the primary point of contact for the migrant workers, or are there other departments also?
No, the Bureau of Foreign Employment, according to the Act of the Foreign Employment Sector, So we are the primary contact point, and even in overseas, the labor section is the contact point for migrant workers. Locally, the prospective workers and their family members, the Bureau of Foreign Employment can be contacted, and we have decentralized places also, and also we have divisional secretariat level, the development staff deployed for foreign employment sector.
Thank you very much, Mr. Mangala Randenia,
Thank you.
Deputy General Manager and Media Spokesperson for the Foreign Employment Bureau. Professor Atula Sumathipala, I'd like to come to you next. We spoke about the need for there to be a change in attitudes almost in how people approach this. You spoke about the need to really reevaluate the strategy, to look at the strategy in terms of how messages are communicated. What should the authorities be doing as the next step in order to get the public to to engage the public and involve the public in containing?
It's very simple. Propagate the idea back to basics. We remember when we had chicken pox when we were children, how people behaved, separate utensils, quarantine, PHI didn't come, it was responsible behavior. Having said that, the most important thing to understand, living in this new normal is a change, drastic change in people's lives. Change always come up with resistance. So what the authorities need to do is to facilitate that resistance through awareness raising and empowering every person to become a leader and think beyond self. That's my message, and that's the very simple idea we should get from top to bottom, bottom up, top down, and that should work. And all the strategies. So my last plea is COVID Center should get some support from psychologists, behavioral strategists as well, to enhance the excellent work they are doing now.
Is there any input that is going in currently from the psychologists and psychiatrists?
Not to my knowledge.
And you feel that this is something that needs to be done as a matter of urgency?
Absolutely, because I mean, it boils down for everybody to, from decision making to implementing authorities, to try and understand the most important thing, to try and understand how people think, what they think, and how they behave. And once you know the grassroots level feelings, behaviors, thoughts, then you can have your implementation strategies to suit that.
And tailor the communications accordingly.
Absolutely.
Thank you very much, Professor Atula Sumathipala, Chairman of the National Institute of Fundamental Studies. Next, Dr. Amanthi Bandusena, Consultant Community Physician at the Health Promotion Bureau. Dr. Bandusena, we spoke about what the role of the Health Promotion Bureau was at the beginning of the program. How do you see the role of the Health Promotion Bureau moving forward from this point? What steps will the Bureau have to take? What steps is the Bureau planning to take to ensure that this situation is contained?
Well, the Bureau will be promoting all these recommended behaviors as much as possible. We have been doing it, and we will continue to do so in coordination with other relevant authorities also. And towards that, as I said, we have the Suvasaria or the hotline which addresses the public queries. So we get the public concerns on a daily basis. So we make sure that we do inform the higher officials also regarding these public concerns and also rumors which need to be managed. So there is appropriate action then taken wherever possible related to that. Then of course with promoting the behaviors, we have a very active Facebook page which is put out by the Health Promotion Bureau. So actually the general public can access that, all the material, the videos, audio clippings, then the printed material with relevance to prevention and control of COVID is all uploaded on that. And actually in the last week we have had 3.8 million posts from the general public coming on this Facebook page. So in addition to that we have Viber, Twitter. So with all these, not only with the traditional approaches of communication, we are also using the social media platforms to reach out to the youth and to other audiences who may not be responsive to the traditional approaches. So the responsibility really does rest with the community, and as Professor Sumathipala said, community engagement is a must if we are to win this that will.
Are you confident that it can be done, that the community engagement that is required
Yes,
to
definitely.
can
If
be
the
achieved?
community does engage, and it is not rocket science, it is practicing some simple behaviors, and it is, well, yes, we have been practicing those over generations and traditionally, so it's just going back to those and not taking unnecessary risks and thinking of others. So I think that is what we need to do.
Thank you very much, Dr. Amanti Bandusena, consultant community physician at the Health Promotion Bureau. And finally, Dr. Deepa Gamage, consultant epidemiologist at the Epidemiology Unit, Ministry of Health. Dr. Gamage, you spoke about how there is a stretch of resources, human resources and the infrastructure, but those programs that the Epidemiology Unit is responsible for are continuing, like not only with COVID but also with immunization programs and tracking and monitoring other communicable diseases. Moving forward, what kind of resource, do you see a resource deficit arising, or do you feel that we will have enough resources to deal with almost any kind of situation?
I think we can't say that resources are adequate. So resources are very limited. Because of that, we have to use the existing resources for the maximum care. I think at the moment the laboratory capacity need to be more strengthened. So that is the one aspect we see that need to be very much to be strengthened. And at the same time, even though we have the adequate hospital capacity at the moment, I think all citizens have a responsibility to make the maximum use of the existing hospital resources. So because of that, I like to give a message to the public. We all have a responsibility to contain this outbreak or to control this outbreak. So now we are facing a very critical stage. So it is our responsibility to think now whether we are going to establish the community transmission or whether we are coming out of this and somehow control the outbreak. So health sector with limited resources, we are working, we all are with other stakeholders, health and the other all stakeholders, we all are working hard to control the outbreak. But citizens, each and everyone is having a big responsibility in facing this to help in controlling the outbreak. So for that, so a lot of people I know these days also they are going there the picnics and the entertainment trips. So it is time to completely stop it at this moment, and limit their social functions, unnecessary social functions. In this Gampaha district also, we have seen around one religious function was there, around 700 to 1,000 people were together. So these COVID positive patients were there without knowing. So these things can happen. Then at one time it will transmit to a lot of community. So these things, this kind of situation has already happened, and we are trying to identify each and every COVID virus infected patients and try to take them out. But there are limited capacities in hospitals. How can we keep everybody in hospitals if the virus is widespread? So some most developed countries, what they have done, so they are taking only symptomatic or the severe cases to the hospitals. But so far we are practicing, if the one person is infected with virus, even though asymptomatic, we take them to one place in a hospital.
Isolated so that they can't spread it.
It is not the quarantine, but isolate in a hospital under medical care. So we have to, I think that is why I am saying that it is a responsibility of each and every one in the country to control this outbreak. It is not the health matter, but for everybody's responsibility.
Thank you very much, Dr. Gamage, Dr. Bandusena, Professor Sumitipala and Mr. Randenier for coming on the program this evening and for speaking about this very timely issue. As I said at the beginning, this is a topic that I had hoped that we would not have to take up again on Face the Nation following the initial run of programs that we had on the topic. But as was said during the program, it is back to basics. We usually end Face the Nation with a quote, so I will end with a quote from Dr. Tedros, the Director General of the World Health Organization. This was back in March when the pandemic was sort of announced, and the World Health Organization had a press conference at which Dr. Tedros said that pandemic is not a word to use lightly or carelessly. It is a word that, if misused, can cause unreasonable fear or unjustified acceptance that the fight is over. At the end of the day, regardless of how your representatives may act, it is up to you as an individual to be safe, be sensible, and be responsible. Good night and goodbye.